Welcome to another episode of Brain Buzz, where we delve into the fascinating world of neurosciences and brain health. I'm your host, Dr. Kimon Bekelis.
And I'm your co-host, Jason Wallen.
Well, today we're going to talk to you about brain tumors, everything you need to know about how to diagnose and treat a brain tumor. Jason, give us some facts about brain tumors.
So a couple interesting facts we have are about 28,000 malignant brain tumors are diagnosed in the U.S. yearly. Over 70,000 benign tumors are diagnosed in the U.S. yearly. And brain tumors are one of the top causes of cancer-related deaths in patients under 40 years old.
Wow. What a better person to have here today to talk to us about brain tumors than Dr. Missios. Dr. Missios is a tumor specialist. He is a neurosurgical oncologist with extensive training. Symeon, thank you for coming.
Thank you for having me.
So we're going to introduce him first to you guys. And so, Symeon, tell me a little bit about how you ended up on Long Island and how do you end up working with us at the Stroke and Brain Aneurysm Center of Long Island?
Yeah, of course. I've been in Long Island since the beginning of 2019. And just a little note, me and Dr. Bekelis, we were in residency together at Dartmouth. And after residency, I completed a neurosurgical oncology
No
fellowship.
stories from residency today, please.
No, don't worry. I completed my brain tumor fellowship at the Cleveland Clinic and then did a second fellowship in endovascular neurosurgery at Thomas Jefferson in Philadelphia. And Dr. Bekelis was already established here in 2019, and that's when I joined.
Yeah, that's great. And in case you didn't realize, Dr. Missios is a perpetual underachiever. One fellowship or one residency wasn't enough. He trained in 2 fellowships, both in blood vessel problems and in brain tumors. So we're very honored to have you here today, one of the smartest people that we have and we will have in this podcast. Thank you for being here, Symeon.
Thank you.
So, brain tumors are an elusive diagnosis. A lot of patients are interested in them. Folks often know friend, relative that has had a brain tumor. And today we're going to try to shed some light into brain tumors.
Mm-hmm.
And we want to get your input, of course. And so tell us a little bit about what a tumor or a brain tumor is.
So a tumor in the brain is just like a tumor elsewhere in the body. It's a tumor. It implies a problem with cell division. Your body is made up of billions of cells.
Right.
Thousands of them die every day. They get replaced by new ones. If there's an error in this process, the cell may die and get replaced by 100 or 1,000 cells instead of just one.
Right.
And over time, that forms a lump. It forms a tumor. So when this process happens in the brain, you get a brain tumor, or it can happen elsewhere in the body, and then pieces can break off and go to the brain, and that can form a brain tumor as well.
So if I'm understanding this correctly, there's generally 2 types of brain tumors that are inherent to the brain, they start in the brain, and tumors that come from another part of the body and then end up in the brain, and that we call metastasis, right?
Right, and that's the big classification is there are tumors that start in the brain from the brain.
Right.
And there are tumors that start elsewhere in the body and they travel to the brain.
Got it. And how does this difference in where the tumor is coming from, how does that affect management?
It affects greatly because there are similarities in management, but there's also great differences. So a tumor that starts in the brain, from the brain, the next sort of big branch point is whether the tumor is benign or malignant,
right,
or not something more aggressive.
Tell us a little bit about that. So if a tumor is coming from the brain, what's the scale in terms of aggressiveness of that tumor?
Yeah, we call that grading.
Okay.
The different grades of a tumor is a scale of how aggressive they are.
Sure.
And the MRI imaging, head CT or an MRI can give you an idea what you're dealing with.
Okay.
But the only way to know for sure is to look at the tumor or a piece of the tumor under the microscope, which implies a surgical procedure to remove at least part of it.
Sure.
And looking at it under the microscope, you can get an idea how aggressive the tumor is and assign a grade to it.
Gotcha.
And so far, up until a few years ago, that was the only way we could know how aggressive a tumor is.
Right.
Lately, within the past 10, 15 years, as genetics has become more sophisticated, now that we can know the genetic fingerprint of the tumor that we're looking at, and that can give us another layer of information in terms of how aggressive it is. So we can see how many genetic abnormalities a tumor exhibits, and that can give us an idea in terms of how aggressive the tumor is.
Gotcha. That's fascinating. So a grade 1, for example, tumor is what you would classify as benign, or
A grade 1 tumor is what we classify as benign. Grades go from 1 to 4.
Gotcha.
They increase in terms of aggressiveness.
Okay.
And a grade 1 tumor is something that we would consider benign. A benign tumor means that it may grow as a lump, but it will not spread within the brain. It will not infiltrate the brain.
And it will not leave the brain to go in another
And
location.
it will not leave the brain to go against. It may push on the brain and
Right.
still cause problems. So benign is sort of
A relative term,
It's a
right?
relative term. A benign tumor can still cause problems,
Right.
but it's not going to infiltrate into the brain.
And you're making a good point. Location is important when it comes to brain tumors, right? It can be a benign tumor that's right on the surface of the brain, easy case. It'll take us 30
Absolutely.
minutes to do. But if it's deep in the brain, then we are limited in what we can do.
Location is everything because the symptoms and the initial presentation depends on location. So if you have a tumor that's near the motor cortex, it will cause weakness much more quickly. If you have a tumor that's close to the frontal lobe, it may not cause symptoms until it becomes very, very large in size.
Right.
And how close it is to the surface determines how easy, how safe a surgical intervention is.
And tell me, what is the most common benign or grade 1 brain tumor that you encounter in your practice?
Yeah, the most common one by far is a tumor that we call meningioma.
Okay.
That's a tumor that actually it comes from the lining of the brain. The brain is within the skull, but there are these membranes that surround it and protect it. And this membrane lines up the brain circumferentially, surrounds the brain.
It's like a saran wrapping for the brain, right?
Essentially, and it's tough and leathery in consistency, and it can give rise to these benign growths that look like lumps.
Mm-hmm.
They're very firm, and if they are small, most of the times people don't know that they have them unless they get a head CT or an MRI for some other reason,
Right.
and we discover them by accident. Once they start growing beyond a certain size, then they start pushing on the brain, and depending what area of the brain is being compressed, you have corresponding symptoms.
Gotcha. And so that's grade 1 tumor, the meningiomas, and
there are other grade 1 tumors.
Right. The most common, I would say, is the meningiomas, and then talk to me a little bit about grade 2 through grade 4 tumors.
Yeah. So again, we're talking about tumors that started in the brain, from the brain.
Right.
So the more aggressive tumors, they arise from the substance of the brain.
Okay.
So, people think of the brain and they think that it's all nerves. It's actually a small subset of the brain is nerve cells. You have more cells that are supportive cells. So they support the neurons, the nerve cells, and they perform a lot of other functions. And those are the cells that give rise to
other tumors, and
most of the brain tumors.
And they're kind of like insulation for the nerve cells. A lot of them, right?
They're insulation. They're support.
Nutrition. Probably.
Some of them are the white blood cells of the brain, if you will. They provide nutrition, exactly, and our brains wouldn't be able to function without them. So these cells give rise to the tumors, to the primary brain tumors, and we call these cells glial cells.
Yep.
And hence the tumors are called gliomas.
Okay.
So you can have gliomas of different level of aggressiveness, and starting with grade 1, but you can also have grade 2, grade 3, grade 4. Grade 4 is the most aggressive type of brain tumor, and it also goes by the name of glioblastoma.
Right. Right.
And that's to signify that you're dealing, unfortunately, with the most aggressive type of tumor, most infiltrative, most destructive.
Gotcha. And so what type of treatment do we have for, of course, you said grade 1 tumors, we generally, actually, let's backtrack a little bit. So for grade 1 tumors, not every, I'm sure, grade 1 tumor needs to come out, right?
Mm-hmm.
We monitor some of them.
Right, if they're small.
And some of them will need surgery or other type of treatment. What do we do when it comes to grade 2 through grade 4 tumors? What kind of treatments do we have for those?
So It depends on the size and it depends on the patient presentation. A surgical intervention is very frequently warranted because you need that for diagnosis.
Right,
As we
right,
said, you need to be able to look at it under the microscope in order to determine what you're dealing with, and that involves either removing the majority of the tumor or a small piece of it, and that involves a biopsy.
right,
Um, Treatment is multimodal. There are different. There's not a single pill to fight these tumors or a single surgery
right,
to deal with these tumors. So treatment typically involves three different aspects. One is surgery.
right,
So surgery is important to establish the diagnosis, provide tissue to the lab so they can tell us what it is. And surgery, we do surgery when it is safe to do it. So
right,
it depends on what parts of the brain are involved and how close it is to the surface.
right.
The other treatment option is chemotherapy. Chemotherapy for gliomas comes in the form of a pill most
Okay,
of the time, and it's actually very safe and in general very well tolerated.
right,
And the other option is radiation.
right,
Radiation for gliomas typically involves a 6-week regimen, 5 days a week, and it's something that the neurosurgeons work in conjunction with the radiation oncologist
right.
for that aspect of the patient's treatment.
Gotcha. So sounds like there is not a single, like you said, not a single path to get to go after these tumors, but you
Mhm.
have to integrate the capabilities of surgery, radiation, and medical oncology or chemotherapy to address these tumors. And why are these tumors, the gliomas, so challenging to treat? Is it because of some something inherent to the structure of the brain, or is it because they're more infiltrative than other tumors? What makes them so challenging?
Yeah, so it's a number of factors. One is you're dealing with the brain,
Right,
so it's a very important organ. As silly as that sounds, I mean everybody knows that. But it's you cannot cut out large areas of the brain because obviously you're going to start harming the patient. Um, these tumors, as they increase in their degree of aggression, they become more infiltrative,
right,
and so the borders of the tumor uh, become what I like to call fuzzy,
right,
meaning that
right,
you do not know where the tumor ends and where the normal brain begins. And because you don't have clear cut margins and borders, it's hard to completely surgically remove the tumor. There's always tumor that will be left behind. And
right,
that's why chemotherapy and radiation are important. The other challenging aspect is that these tumors constantly change their genetic profile, meaning that chemotherapy works for some of these tumors, but these tumors mutate,
right,
and as they mutate, they can become more resistant
right,
to chemotherapy, just like a bacterium can become resistant to certain antibiotics.
right. So they're adapting as you're trying to
Exactly.
treat them.
And when it comes to other forms of cancer, like lung cancer, we have t- you know, 10, 20 different chemotherapy agents to choose from. So if
Right.
one stops working, we can pick another one. Unfortunately, when it comes to gliomas, uh, we don't have that many chemotherapy options yet.
Gotcha. So talk to me a little bit about awake surgery. I get that question a ton. When we're treating anything really in the brain, and even if we're treating a brain aneurysm, people are like, "Why are you going to do this awake?" It's the most appropriate field to talk about awake surgeries is inherent, intrinsic brain tumors, right? Tell me a little bit about that. Why is it useful? When do you use it? And
Yeah, it's a very sort of popular concept. It makes the news a lot.
right,
Um, Realistic, and it is a very important technique,
right,
and it has its uses. It has its challenges because you need a specific kind of anesthesia. The patient wakes up during part of the procedure. And essentially, you use it when a tumor is very close to an area of the brain that we call an eloquent area, typically an area of the brain that controls movement or
Right.
speech.
Right.
And again, because we said the borders of these tumors are fuzzy, so you don't know where the tumor ends, where the normal brain begins. If a tumor is up against the speech area, for example,
Right.
and you don't know exactly where the speech area is, awake surgery can be very helpful because once the brain is exposed, the patient can wake up and you can test different areas of the brain, so you can determine exactly where the speech area is and avoid it during your resection. I'm obviously oversimplifying this process.
Right. But these are very fascinating
I mean,
things.
that is extremely fascinating. And I mean, it's so the patient gets put under,
Mhm.
and then in the middle of surgery wakes up.
Right.
So
So
this sounds like a scene from Hannibal. I mean,
It is not far from,
it
actually.
is done in a very, very controlled fashion.
uh-huh.
So the patient, so that's why you need a very good anesthesiologist
Mhm.
who's trained at this, and you need a very specific anesthesia. So the patient is asleep while you make the incision, while the bone is removed.
Mhm.
And once the brain is exposed and you have the surface of the brain exposed and you start to test it, the patient wakes up. They're not completely fully awake.
Okay. So
But
that,
they can carry a conversation with the surgeon,
Yeah.
which is kind of freaky, of
that
course.
is insane.
But the anesthesiologist gives them medicine so that they don't feel any pain
Uh-huh.
and they don't remember anything afterwards. So they wake up
Has
in
anybody
a
like woke up and
twilight.
freaked out?
No,
No.
no. The anesthesiologist won't allow that. If something like that were,
I mean,
I
'cause
mean that's not safe.
yeah, no. I mean, I know me personally. If I knew I was going to wake up in the situation, I'd be
No,
like
patients
spazzing.
wake up in a twilight, just enough so that they can communicate with you, and then it's not something they cannot remain in that state
Mhm.
for a long period of time. You have a certain window.
It's amazing.
That's the other thing, when you do these surgeries, like Symeon says, you have to take advantage of that window. It's not a situation where you can be testing for hours, because the patients get tired, and the effects of the anesthesia is not as strong, and
Right.
you can sometimes they can get too sleepy from the anesthesia, then you cannot really continue the surgery. So you gotta, these are really, really intricate operations. The
But it's
ones
a
that are
very
awake.
small subset of patients that require something.
Right, for the amount of publicity that awake
Yes,
surgery
yes.
gets, it is the
It's,
2 to
it is
5% of the
disproportionate.
operations
Yeah.
that
Of
you
course,
do for
you're
brain.
always going to hear about the the glitzy stuff.
Right,
You know.
that's exactly right. And so that's when it comes to intrinsic brain tumors, right?
Mhm.
Brain tumors that come from the brain itself. Um, what happens with tumors that come from other parts of the brain, of the body, into the brain, right? That what we call a metastasis. And generally speaking, when people hear the term metastasis, they panic. It almost feels like a death sentence. Is a metastasis in the brain from a brain tumor, say from the lung or another organ, is the metastasis a death sentence in and of itself, or no?
Um, no, we don't like to use that term. It certainly presents another layer of complexity in the
Right.
patient's care, but we've actually gotten very good as a medical community over the past, 15 years at dealing with brain metastasis to the point where the majority of patients who have cancer
Right.
that metastasize to the brain, the majority of patients, if they end up dying, they end up dying because of the what we call the systemic disease,
Right.
meaning the amount of cancer they have in the body in places other than the brain.
Right, and that was the point I wanted to make, that really we can take care of the brain metastasis. It's not going to be what's going to change your prognosis or your lifespan, which is pretty amazing. A lot of patients think that that's it for them, but that the brain metastasis we can. And how do we do that?
So again, it depends on how the patient presents. It
Right.
depends on how many brain metastases they have. If they present with 1, 2, 3, very different outcome as opposed to if they present with 20 or 30. The Again, it's a combination treatment, but you are limited in the sense that chemotherapy does not get into the brain. So
Right.
you're left with two main options. One is radiation. The other is surgery. Radiation works great for tumors that are typically on the smaller side. I like to say it works better for tumors that are about the size of an olive or a small cherry or smaller. So
Right.
anything smaller than 2.5 centimeters radiation works very well for. And you can target as many tumors as you want. There are different kinds of different ways of delivering radiation. One is more specific, the other covers the whole brain, and we call it whole brain radiation. The more specific one, we call it stereotactic radiosurgery. And then surgery is reserved for the larger tumors, typically 2.5, 3 centimeters or bigger,
Right.
which tumors that are close to the surface,
Right.
surgically accessible, and tumors that cause a lot of swelling and a lot of symptoms.
Right. And stereotactic radiosurgery for those of you guys, you might have heard some terms like gamma knife,
Mm-hmm.
right? Linux, cyberknife. These are just different machines that deliver radiation to the
Exactly.
target, and we call it radiosurgery, not because there's any knife or surgery involved.
But because it's very precise.
Precise, and it's a single shot most of the time. Sometimes you have to do a couple of sessions, but most of the times it's a single shot radiation, so you don't go back and forth. So the difference with the glioma type of radiation, where you have several sessions and you go back to the radiation oncologist, in this type of radiation, it's typically a single shot, 1 day type of deal, and that treatment is very effective. And that is kind of a lot of patients have a hard time coping with that notion that radiation is one afternoon and that's it. That's pretty amazing.
Right. Yeah. Because most patients have the notion that radiation is gonna make them lose their hair,
Right.
or get
Exactly.
really sick afterwards, or get really weak. And certainly sometimes radiation can do that, but with radiosurgery, especially for brain metastases, it's typically done in 1 or 3 sessions, and it's very quick. It's only 10, 15 minutes
Right.
each session, with minimal side effects. So it has sort of revolutionized the way we treat and manage these conditions.
Right. So, now that we have a bit of a general understanding of what a brain tumor is, what type of brain tumors exist outside of the brain, inside the brain, how they behave, what the different treatment options are, maybe we'll go on to some questions that we got from the audience before this podcast through social media. So, Jason, maybe give us a couple of questions.
Absolutely.
And I'm sure we've covered a couple of the questions already, but
Yeah, and I have to say, all of us in the medical field, we deal with heavy stuff, but I think whenever it comes to cancer, you're dealing with the heaviest of,
Mhm.
because a lot of times, people are thinking that that's the end right then and there. I mean, we deal with brain aneurysm, strokes and stuff like that, but this is something that it's a whole process from diagnosis to what we're going to do treatment. I mean, half these names on this list sound like if I mispronounce them, the furniture's going to start levitating. It's all complicated.
and honestly, it takes a special neurosurgeon to deal with these issues, right?
Yeah,
A lot of us are, these interactions with the patients and
and
frankly,
family.
family.
Yeah.
And most of the times, especially in younger patients, you have this issue where, you have to talk to them about sometimes end of life arrangements. And sometimes you have to deal with uncertainty, right? It's not, oh, you have this brain tumor, this is how long you're going to live. We all know patients with very aggressive tumors that have lived for a very long time, or they're still alive, and we cannot really predict, and it takes a special kind of person like Symeon, like
Mhm.
Dr. Missios, who's able to deal with these patients and also deal with these diagnoses and give hope, because this is what it's all about. Give hope and get them through the next stage of their life.
Yeah, that's definitely a certain kind of individual. So thank you. Some questions that we have. Some basic warning signs of a
Mhm.
brain tumor.
Um, yeah. So it varies, but in general, some of the common presenting symptoms are a persistent headache. So we all get headaches from
Mhm.
time to time, but if the intensity of the headache is different, if it's persistent over a few days, that's certainly a sign of concern. And it's so easy to get a head CT these days. Um, so that's definitely one of the most common
Mhm.
symptoms. And seizures. A lot of times, patients present with seizure activity that they've never had before. Any
And what
focal,
is a seizure? Like, how would they know they're having a seizure?
they wouldn't necessarily,
Okay.
but the people who are around them, their families would. So a seizure is like hitting the reset button on a computer. So everything, the brain sort of the nerve cells in the brain start firing at times when they shouldn't, and
Right.
people lose consciousness. Their muscles start convulsing without their voluntary control, and this is a process that can last for a few seconds up to a couple of minutes,
Right.
and then the patient is very, very sleepy afterwards.
Okay.
So all of that, is worrisome enough that they end up in the hospital.
Gotcha.
Focal neurologic deficits, that's a sort of a catch term. That means that weakness, numbness, difficulties with speech, difficulties with vision.
Right. And for those
And
that
this
are
overlaps with stroke.
right, for those folks that are following our podcast, I was about to say
Yeah,
that
me
we
too.
we had a very extensive section on stroke, and we were talking a lot about fast
Hmm.
face arm speech, time to call 911. So of course, if you're having those symptoms like Dr. Missios is explaining, call 911, go to the hospital. Very frequently, Dr. Missios will tell you this patients would come to the hospital, we activate the stroke code, the stroke team gets activated, we get all these advanced imaging, and then we see that it's a brain tumor actually that's causing those symptoms, and then
Yeah.
care is transitioned to that direction. So often these tumors, these pathologies masquerade as a stroke.
Yeah.
Yeah, a tumor can mimic a stroke,
Well, I was just going to
without a
say,
doubt.
the common theme of all these signs and symptoms for most of neurological disorders, unfortunately, is headaches.
Right, right.
So, I mean, as a layperson, must be sitting there thinking every time I get a headache, it could be this whole gamut of this is it.
Well, that's why I said
Right,
persistent
Yeah.
headache that is different from the normal background.
right. So exactly what he said is very different, but also characteristic of something going wrong, right? But both for brain tumors, for aneurysms, for anything, people get headaches. But what we care about is the different headache, and in any form, different in consistency, different in nature. My headaches have always been this dull pain in the forehead. Now I'm getting these explosive headaches,
Mm.
or a different location, different frequency. I've been getting headaches once a week. Now I'm getting headaches once a day. That's something that we need to look into. So headaches that are changing is a very bad sign, generally speaking. So that's a good time to talk to your primary care doctor to get a scan. And it's not an everyday headache, right? So that's very, very important. So the words he used are very, very important when it comes to diagnosing these tumors and getting a warning sign.
And you had mentioned CAT scan for one of the ways to diagnose it. What are some of the other common?
Yeah, so the two primary ways of taking a look at the brain and getting some pictures, head CT, a CAT scan, that's typically the first screening test because it's quick. It gets done within seconds, and you don't have to go through a tube. And it's so prevalent and so easy to get. If the CAT scan looks concerning in any fashion, or if the CAT scan cannot give you a lot of detail in terms of the structure of the brain. It's very good at when you're looking for blood or any fractures in the bone. But
Right.
when you want to look at the brain substance itself in more detail, then an MRI. And typically an MRI with the dye, so with
The
contrast.
Now, can you tell right from the imaging if it's benign or cancerous?
You can have a very good idea. There are certain features, such as the degree of swelling or how irregular the borders of the tumor are, that can sort of steer you in the direction of knowing whether something is benign or malignant. The way to be 100% sure is to look at it under the microscope.
Okay, so
Right.
biopsy.
Right. And maybe we do two more questions because we're running out of time.
Yes.
And I know you have about 80 questions from the
Oh
audience.
yeah, yeah. I mean, a lot of people. This, like I said, heavy topic. A lot of people are concerned about it. If somebody has a benign tumor, can it turn malignant?
Yes.
And what he's going to tell you is probably the term benign and malignant in the brain is when it comes to grade 2 through grade 4, right? It's
Right.
more levels of
So
aggressiveness.
when you're talking about meningiomas, it's the vast majority of them are grade 1. There is a very small subset of meningiomas that can be more aggressive, so they can be grade 2 and more invasive. But that's very rare. When it comes to gliomas, so the tumors that start from the brain itself, they are, if they are low grade, meaning that they're grade 2, so these are the very slow growing types of tumors, they can over time, and time could be years, turn into a more aggressive form. And that's because, as we said, remember, these tumors unfortunately accumulate mutations, and the more mutations they accumulate, the more aggressive they become. When that happens, if that happens, it's hard to know, but it is something that can happen, so we warn patients about. That's why treating them promptly when they are lower grade has value.
Does that
Because
make a difference if you treat them as a grade 2 before they transition?
there's a big topic of debate on that, but the latest knowledge that we have is that yes,
It does
it
make a
does make a
difference. Okay.
difference. Especially because you're leaving less tumor. If you're treating them and you can leave less tumor behind, you're decreasing the chance that it will
Change.
become,
Right,
that it
right.
will change over time.
And our last question is, I'm kind of summing up a couple of different ones in this. And tumors in children,
Right.
how do they differ? And, are the treatments different?
Right. And for all of us, that's the most dreaded
Yeah,
type of topic.
anything with kids.
Yeah.
Yeah. The types of tumors differ.
Okay.
Um, Kids in general don't develop metastatic cancer to the brain,
Okay.
so you don't see many of those tumors. Also, kids don't have meningiomas typically unless they have a genetic condition. So the majority of the tumors that you see in kids tend to be tumors that start in the brain from the brain, not necessarily gliomas, but other types of tumors that start from the brain itself.
I'm going to
Uh,
sneak one more little question in there because I meant to ask it earlier. When you are
I was about
removing,
to sneak a question in there.
I'll go first because maybe my question's the same as yours. Who knows?
Let's see.
When you remove anything from the brain,
Yeah.
being a tumor, how is it? Is it different than the actual brain tissue itself, or are you removing actual brain tissue?
Oh, great
that's a very
question.
good question. So,
See, I didn't want to skip it.
No, it was better than my question.
um, I think another way to phrase that is how much visual feedback we have. So when you're so yes, the majority of tumors do look and feel differently from the surrounding brain. So
So
that
is it brain tissue that became cancerous, or into a tumor, or is it separate tissue that grew within it?
so when you're dealing with meningiomas, it's a separate tissue that gets pushed into the brain, and you have to sort of develop a plane between the tumor itself and the brain when it comes to gliomas, they are part of the brain. So you have to go around the tumor, and the tumor itself is of different consistency than the surrounding brain. So it gives you you have some visual cues when you're getting into normal white matter, for example, and you're getting beyond the extent of the tumor. Where it becomes very, very challenging is with the low-grade gliomas. The low-grade gliomas, a lot of times, are indistinguishable from the normal brain. And you cannot rely on visual cues as much. And that's where using techniques such as neuronavigation, which we didn't have a chance to talk about, and surgeons' experience and tactile feedback it makes a big difference.
We could talk about this all day, I'm sure.
Oh, for sure. I mean, when when we told Symeon that we'll try to do this in 30 minutes, he said, "Are you guys crazy?" But no, I mean, obviously, we'll have Dr. Missios come back for another podcast, and we'll talk a little bit more in detail about some of these notions that he mentioned, like neuronavigation, stereotactic, radiosurgery. We'll talk a little bit about novel treatments, immunotherapy, targeted genetic treatments. But we just wanted to set the tone and talk a little bit about the general
Yeah.
aspects and a little bit about general knowledge of tumors, since we get all these questions, right? And do you have any other sneaky questions you want to get in
No,
there?
I have a whole list, so we'll deal with it next time.
Okay, sounds good. Well, with that, I want to thank both of you, and of course, thank Dr. Missios for being here
Yes,
with
thank you
us.
very much.
Of course,
Thank you
thank
for being here. Of course, guys, thank you for listening in to another episode of Brain Buzz. You can always find us on our website, www.strokecarelongisland.com. And you can always subscribe on our YouTube channel, and you can find all our podcasts there. And that's you can find it at Stroke and Brain Aneurysm Center. Thanks again. Take care.